All right, guys, so what we're going to do today is talk about Chapter 19, Diabetic Emergencies and Altered Mental Status. All right, we'll talk about some pathophysiology, assessing the patient with altered mental status, diabetes itself, and other causes for altered mental status. So first, pathophysiology. Normal consciousness is regulated by a series of neurological circuits in brain that comprise a reticular activating system. Wow, okay. Reticular activating system is responsible for the functions of staying awake, paying attention, and sleeping. RAS helps keep the person alert and oriented. Requirements for the brain tissue of the RAS to function are oxygen to perfuse the brain tissue, glucose to nourish the brain tissue, and water to keep the brain tissue hydrated. So if you look at these things, we know that there is a system called the reticular activating system that is responsible for the functions of the brain and basically acting normal. And for that system to work properly, we need oxygen, glucose, and water. So some causes of altered mental status: deficiencies in oxygen, glucose, or water to the brain tissue. Trauma can cause that, infection, toxins, stroke. All right, so you got a block in the blood vessels going to the brain that can cause altered mental status. Or there could be another problem with another system, such as hypoxia due to asthma. So hypoxia is what? Low oxygen, right? So that's one of the three things that the body needs to function properly. So when we're cutting off the oxygen, then you can have somebody with altered mental status. So how do we assess that person with an altered mental status? They can be dangerous. So these altered mental status people, a lot of times they'll act drunk. We are not allowed to determine whether or not they're intoxicated. So it may seem that they are, but we have to think that maybe something else is going on. We always have to consider the scene safety of ourselves and include law enforcement. So if you have that combative patient that's fighting with you because they're altered, whether it be drugs or alcohol, or it could be a medical problem. They could be having a stroke. They could be hypoxic, whatever it is. So always worry about your scene safety. And if you have a combative patient, probably want to get that police car on its way. Primary assessment. Hypoxia is one of the most common causes for altered mental status. So always consider the possibility of an airway or a breathing problem. So we got to identify our life-threatening problems, our ABCs, right? So consider oxygen administration if we think that they are hypoxic, if they're showing signs of cyanosis, if they have an airway issue, we have to treat that first, right? ABCs as far as our primary assessment. All right. Pay attention to in case you might need to reposition the patient. If they're laying down in a certain way, that could be cutting off their airway, or if you need to suction for them. All right. Something else that's real important is determine the baseline mental status for the patient. We go to a lot of resource centers and things like that, people with developmental disabilities, and they don't necessarily act what we might call normal. But a caregiver, family member, whatever it is, can probably tell us, oh no, he is acting, this is his normal, or this is not his normal. So those the family members or the staff at these places are great resources for us to tap into. Is he acting normal? Is she acting normal? All right. So we've already determined we have no life-threatening injuries going on. Our ABCs are covered. Now we're kind of working on our secondary assessment. All right. Thoroughly examine the patient exhibiting new, unusual behavior. Even slightly altered mental status can indicate serious underlying conditions. So they'll start to act just a little bit loopy. And something very, very serious could be going on. All right, body systems exam and complete history may reveal information about the suspected cause of altered mental status. So if we do check the systems, we ask the right questions, we might determine, oh, this patient has Alzheimer's, or this person has a diabetic history and they haven't eaten yet today, or they took too much insulin, whatever the case is. And we'll talk more about diabetes here in a little bit. All right. Interview family members and bystanders to obtain patient's baseline mental status. We already talked about this. Family may be able to provide important patient information. All right. Patient medications may point to relevant medical history. So does the person have a prescription, or do they have insulin laying around? If we see that, okay, this person's probably a diabetic. Wouldn't hurt to look at the name on it and see if it matches the gender of the patient. And that's not always 100% accurate, but it's something to look at. We can look for the medical alert bracelets or other health-related items at the scene. So if you have a bracelet on, check it. Sometimes they wear a necklace or like a pendant around their necklace saying diabetic, things like that. Note on pediatrics. Children may not be able to answer questions in the same manner as adults, and therefore mental status is often difficult to establish. And that's why it's important, again, to talk to the parents or the caregivers. Are they acting differently than normal? All right, on to diabetes. Glucose. So glucose is a form of sugar. It's the body's basic source of energy. Body cells require glucose to remain alive and create energy. Okay, so we need some type of sugar in our system for the body to function properly. All right, the glucose molecule itself is pretty big. Okay, it will not pass into the cells without insulin. Okay, so now you can have sugar running around through your bloodstream, but it can't necessarily get into the cells without insulin. Okay, so insulin is the key. So if you look at this picture here, the pancreas releases insulin. All right, the blood sugars in this diagram is already in the bloodstream. So the insulin and blood combine and they enter the cell. So the insulin allows the sugar to get into the cell. If your body is insulin resistant, like a type 2 diabetes or type 1 diabetes, meaning you're born with it, and your body doesn't utilize the insulin the way it's supposed to, then people will have high blood sugar because the body can't use it. And that can be real bad as well. And we'll talk about what that's called here in a minute. Okay, insulin, produced by the pancreas. It binds to the receptor sites on the cells and allows glucose molecules to pass into the cells. All right, sugar intake insulin production balance allows the body to use glucose efficiently as an energy source. So what this means is, just like I said, the pancreas releases the insulin goes to the cell and says, hey, glucose, come on, you can come in this way. All right, and it lets it in. The sugar intake and the insulin production balance is very important. So if you have too much insulin, you might drop your blood sugar. All right, if you don't have enough insulin or your body doesn't use it properly anymore, then your blood sugar level is going to be high. I hope that makes sense. All right, there's two types of diabetes. Type 1 means that the pancreatic cells do not function properly. Insulin's not secreted normally, not enough insulin to transfer circulating glucose into the cells, and then typically synthetic insulin is required for the body to function properly. So people will inject themselves with insulin, and that's a varying dose that the doctors will prescribe for these people. And these diabetic patients, when they're not altered, they know this stuff way better than anything that I can teach you. But when we get there and they're altered and they can't answer these questions, that's why it's important for us to understand how these things work. Okay. So type 1 is generally you're born with it. You're either not getting enough, you're not getting any insulin. One of those types of things is going on. So these people have to inject themselves with insulin. Otherwise, their blood sugar is going to skyrocket. Okay. Type 2 diabetes, the body cells fail to utilize insulin properly. Pancreas is secreting enough insulin, but the body's unable to use it to move the glucose into the cells. Condition is often controlled through diet and or oral anti-diabetic medications. So type 2 is acquired. in my opinion. This is type 2 diabetes, generally speaking, and there is some hereditary things that can happen. But generally speaking, if you pump yourself so full of sugar all day, every day, for a very, very long time, your body is constantly releasing insulin. And what that does is it makes your body resistant to the insulin. So it keeps having to dump more insulin to bring the blood sugar down. It'll dump more and more insulin. It'll keep dumping it into your bloodstream in order to get the glucose where it needs to go. So your body's becoming resistant to your own insulin, and then you develop type 2 diabetes. A lot, and where this says condition is often controlled through diet and or oral anti-diabetic medications, there's a lot of science pointing towards these low-carb diets, getting off the refined sugars and that kind of thing. And it, in some people, has essentially cured type 2 diabetes because they're regulating their insulin levels a lot better, so your body's not constantly dumping it in, if that makes sense. Okay, we have a couple of conditions that we have to worry about with our diabetic patients. We have hypoglycemia. Hypo means what? Low blood sugar. Low blood sugar is called hypoglycemia. All right. Some causes of that could be a diabetic person takes too much insulin. So we got a lot of insulin that's clearing out all that blood sugar, but you don't have enough sugar coming in. The diabetic person doesn't eat, so they're not getting those carbohydrates and the sugars that they need. Diabetic overexercise or overexerts themselves. So they could overexert themselves and actually cause your blood sugar to drop. Vomiting and diarrhea is another one, because the sugar will just go right through your system. Or if they're vomiting, they're not getting it. They're not even getting it into their system in the first place. Diabetic increases metabolic rate, so fever or shivering. So if they have a fever, they might have some hypoglycemia going on. A little more about hypoglycemia. So what are the signs of hypoglycemia? So we know that their blood sugar is low at this point for whatever reason that is. And we can ask the questions, when was the last time you ate? Or ask the loved one, when was the last person they ate? Did they take their insulin today? Did they take it the way they're supposed to? Did they take too much? All right, so but what we'll see in the hypoglycemic patient is a very rapid onset, okay? This happens very quickly. It may present with an abnormal behavior, mimicking drunken stupor. So the hypoglycemic patient will be acting drunk. My uncle has type 2 diabetes, and he acts, it's almost can be like stroke-like symptoms when his blood sugar gets real low. So he's slurring his speech a little bit, and you think this person's intoxicated, right? All right, pale, sweaty skin. Okay, we might see some of that. Tachycardia, so their heart rate's going to be increased, their breathing is going to be increased, and they can have seizures. Now, if a seizure, if you have a hypoglycemic induced seizure, this is very, very serious. That means that their blood sugar is very low, and we need to do something for them right away. Okay. So what is hypoglycemia doing to your body? Okay, it's starving the brain cells of sugar that the brain needs, okay? Causes your altered mental status, unconsciousness, and permanent brain damage. So if your brain doesn't get enough sugar for a long period of time, you can have permanent brain damage. All right, so on the other side, we have our hyperglycemia. Hyper meaning high. The causes of this could be a decrease in insulin. Okay, so now your body's not having enough insulin that it needs, and that may be due to the body's inability to produce insulin. So your body can't produce it, it's not producing it efficiently, or it's produced so much and you become insulin resistant that the insulin is not working as the key to get the sugar into the cells, okay? This may exist because insulin injections are not given in sufficient quantity. Now, we're not going to try to figure that out. These people are dealing with doctors who make the decisions of when and how much insulin they need. We don't administer insulin as basic EMTs, but that could be one of the reasons for the hyperglycemia. Stress, increasing dietary intake could be some causes of it, some more causes of it, excuse me. Signs, developing over days or weeks. So this takes a lot longer to kick in. This is a person who hasn't taken their insulin the way they're supposed to for a period of time. They could be real thirsty and hungry, increased urination and nausea, okay? I've had these patients before where they're diabetic. We'll get into that in a minute, but they're in a serious condition where their sugar's been really high for a really long time, and they're actually unresponsive. And there's not a lot we can do as basic EMTs to treat this, but we have to identify it if we can. Have ALS coming and get to the hospital quickly, because they are going to do what they do to try to thin out their blood a little bit so there's not quite so much sugar running around in there. Some of these people will just refuse for whatever reason to take their insulin. And I've had those before. They'll tell you they refuse, they don't want to take it. Well, it's going to kill you. I don't want to take it. Okay, well, why'd you call 911, So again, hyperglycemia, profound dehydration. So they could be very, very dehydrated. Excessive waste products are being released into the system, and diabetic ketoacidosis. Let's see if we have a slide about that. We do. Okay. Diabetic ketoacidosis. Now, this is a condition that is caused from long-term severe high blood sugar. And I say long-term, I mean days probably. Okay, we're not talking years here. We're talking days, but a lot longer than what hypoglycemia is. All right. So profoundly altered mental status. A lot of times these are the ones that we find that are very out of it or completely unresponsive altogether. They could be in shock, which is what? Hypoperfusion, right? Have rapid breathing and acetone odor on the breath. So not every time that I've had a DKA, which is diabetic ketoacidosis, not every time that I've had one of these patients, I've been able to smell that on their breath, but you will occasionally smell, it's kind of a sweet, fruity smell on their breath. And that is an indicator of diabetic ketoacidosis. Now, if you don't smell that, that doesn't mean that they're not in diabetic ketoacidosis, but that is an indicator for it, okay? We're assessing these patients. Again, we talk about this a lot. Scene safety, right? Because our safety is number one, okay? If you have to back out of a situation because it's not safe, you will be completely justified to do so, okay? Perform the primary assessment. Identify the altered mental status, because identifying the patient's level of consciousness in that is part of your primary assessment, right? So try to find out if they're acting normal, all right? Let's get into the secondary assessment. So let's get a history of the present episode. What happened this time? Why are you right now calling 911? Okay, that's very important. How did it occur? What time did it occur? How long did it last? Or how long has it lasted? What kind of symptoms? Okay, mechanism of injury. Okay, we could be thinking that this is a medical problem, but it could be a trauma. So it doesn't hurt to ask, hey, did you fall down? Did you fall down a flight of stairs and smack your head? Okay, these things are very important. That's when we get into our sample questions, right? Sample is what? Signs and symptoms, allergies, medications, pertinent medical history, last oral intake, and events leading up to. These are going to give us a lot of the assessment questions that we need to be able to determine what's going on with this patient. Determine a history of diabetes, okay? We can question the patient or the bystanders, family members, whatever it is. Look for those medical identification bracelets or pendants that we talked about. Look in the fridge or elsewhere. So I don't get into the habit of searching through people's refrigerators. It doesn't hurt to take a look at the fridge and see if there's some medications on a magnet stuck to the refrigerator. We don't really want to go rooting around too much through people's things. But I suppose if you were very desperate for information, you could probably check their refrigerator and look and see if you see any medications or insulin in there. Perform blood glucose monitoring if your local protocols permit you to do so. Our local protocols do permit you to do so, but you have to credentialize in those every year. So when you get back to your stations, you get your EMT cards. Once a year, you'll do a credentialing for the REMAC, which is our region, and you will test every year on glucose monitoring. So that'll be something that's done at your stations. I'd be more than happy to show you guys that if we have time, real briefly. Okay, blood glucose meters. That's the glucometer, like we were just talking about. You're going to credentialize. It measures the amount of glucose in the bloodstream. It's often used by patients at home, sometimes used by EMTs. Again, we do, but you have to credentialize in it. It's a handy dandy little device. You'll prick their patient's finger. You'll put a little test strip in your machine, test their blood, and it'll give you a number. Blood glucose measurement. Okay, so now here we get into some very specific numbers that aren't really what we follow exactly anymore. There is no set number on normal blood sugar. This right here says less than 60 in a symptomatic diabetic. We're going to say it's hypoglycemia. Okay, so if you measure their blood sugar and it's less than 60, then they're hypoglycemic. But everybody handles it differently. I've seen blood sugars in the 50s and people have been normal. I've seen blood sugar in the 70s and people are acting a little off. So there's no set number. Do not, set in stone that 60 number, okay? But if you see it in the lower end and they're acting altered, then that's probably what's going on, okay? Less than 50 significant alterations in mental status. So generally speaking, not with everybody, but generally speaking, if it's less than 50, it's getting very serious. I've seen them in the teens before, and these are like unresponsive patients that you think they're having a stroke. Now, low blood sugar will mimic a stroke-like symptoms. You don't want to give somebody a $20,000 helicopter ride to Hammett because their blood sugar was low. So it's very important for us to check these things and see, oh, this person's at 22 and they're unresponsive. They're probably hypoglycemic. Let's get them some sugar and see if they come around before you put them on that helicopter, okay? Blood glucose measurement greater than 140 is called hyperglycemia. Not necessarily, because 140 could be normal for that person, okay? 140 is a little high. But it's nothing to be terribly concerned about with some people, especially if they just got done eating a cake or a bunch of cookies or something like that, okay? Greater than 300 for a prolonged time, dehydration and other serious symptoms. So if I see somebody with 300, I am going to be concerned because that is very high, okay? Special glucometer readings may display word instead of a number, high or low. Okay, generally speaking, and each manufacturer is a little bit different, but if your meter says high, it's probably more than 500. The meters we have here at work are, it says high if it's above 600. So check your manufacturer for whatever you carry on your ambulance. But if you see high, you know it's high. It's above 500, okay? And low, generally speaking, is less than 15 on their blood sugar, okay? Again, check your manufacturer because they're all slightly different. But again, if it says low, no matter if your machine says low at 15 or 20, if it says low, it's not good, okay? So just remember that. All right, here's a picture of a glucometer here. We have some very similar to these. One thing to note, I have seen this in the field before. The Lancets on the right-hand side there, the blue things, the white things with the blue tips. Any Lancet that you're going to use in your ambulances do have to be one single-use Lancets. When you buy a glucometer at Walmart or wherever, it comes with one where you unscrew it and you put a new new needle in there, a little poker, and then you screw it back together and you use that device over and over and over again. It's that you cannot use that on an ambulance. It has to be single use. So if you guys happen to have any that are reusable Lancets, where you just change the little needle out, throw them away. You got to get these single-use ones because it's too easy to cross-contaminate. Okay. All right. Occasionally, one can treat person with mild hypoglycemia and minor altered mental status by giving them something to eat. Okay. So what you can do is we carry glucose on the ambulance. They're these little tubes and they taste gross. You can give them glucose, and we'll get into that when we talk about med administrations a little bit, but you can give them glucose or orange juice, something high in sugar like that. If they're alert enough to eat, where you don't have to worry about airway issues, you can do that. And you can sit with a patient for a little bit and try to get their blood sugar back up and check it again. And if it gets up to a normal level, the patient's feeling fine, you're okay to sign them off, to do a refusal form. And I always like to try to encourage them to go down and get checked at the hospital, because something's probably off with their medication, but they don't have to, because at this point they're alert and oriented. So if nothing else, at least recommend that they talk to their doctor and try to get some things moved around. Okay, but never, 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 never administer food or liquids to a patient that's at risk for aspiration. So if the person can't talk, if you don't think that they can swallow, do not put anything in their mouth. Even the glucose tubes that we have, if they can't swallow it, don't give it to them. Okay. Some people may tell you that you can put it on a tongue depressor and put it in the side of their mouth. Okay, that's fine if they're alert enough to say, yeah, let me just suck on this thing here and it'll absorb into my, I'll digest it. Do not do that if the person's unresponsive. Okay. Oral glucose. Okay. Criteria for administration. So when are we going to use our glucose? We are going to use it for a person with a history of diabetes, they're having altered mental status, and they're awake enough to swallow. Now, we're going to take it a step further because we can check glucometry. As long as you're credentialized to do so, check their blood sugar. And I always tell people, if you are very, very suspicious that their sugar's low, and this is a hypoglycemic problem, and your meter says, 110, whatever, something in a more normal range, it's not showing low, check it again. Because sometimes, checking the blood sugar is a process that you really have to follow. And we'll talk about this briefly when we get a chance, but you have to clean the site. You have to poke the finger. You have to wipe that first drop of blood and get the second drop of blood on the machine. If you mess up that process at all, or the finger wasn't perfectly clean, and you're any bit suspicious that you might have a false reading from your meter, just check it again. Prick it on a different finger, and that's totally acceptable. Okay. When we administer the glucose, the patient squeezes glucose from the tube directly into the mouth. You can administer you can administer glucose using a tongue depressor. Like I said, you can put it on the tongue depressor and you can put it in the side of their mouth only if they're responsive. Okay. There's a picture of it right there. All right. Oral glucose. All right, recess after administration. So it takes a few minutes for this to kick in, but it's usually pretty quick if the person is hypoglycemic and you're bringing their sugar back up. Usually it's a pretty quick response. They come back to a normal state. Now, if the condition doesn't improve, consult medical direction about whether to administer more. Okay. So hypo and hyperglycemia compared. So, we got to keep these two separated because they are very polar opposites of the scale, okay? So the onset, when we're comparing the two, hyperglycemia has a slower onset, while hypoglycemia tends to come on suddenly. So low blood sugar happens pretty quickly, okay? High blood sugar takes a little while, days or weeks, probably days to kick in, okay? Hyper, which is high blood sugar patients, often have warm, red, dry skin, while hypo, low blood sugar, have cold and clammy skin. Okay, so the real high blood sugar patients are probably going to have warm, red, dry skin, while the low blood sugar going to be cold and clammy, right? Diaphoretic. Okay. The high blood sugar typically has that acetone breath, but not all patients, like I said before, not all patients exhibit this sign. So if you smell that on their breath and they got the skin and their diabetic history and you think it's high and you checked it with your glucometer, okay, this is probably what's going on. Okay. Other causes. Trying to find a way to. Sepsis. Collection of problems associated with response to infection. It occurs when steps normally taken to fight infection move from the local site and become a systemic problem. If it's severe enough, the microbes of the offending infection can release toxins that cause harm in the cardiac output. Sepsis is essentially a blood infection, and sepsis is a very, very serious condition. Okay, that can cause altered mental status. When we are assessing these patients, things that may indicate severe sepsis would be altered mental status, increased heart rate, respiratory rate, low blood pressure, high blood glucose, decreased capillary refill time. Seizure disorders can cause altered mental status. In normal brain function, if the normal brain function is upset by an injury, infection, or disease, the brain's electrical activity can become irregular. Irregularity can bring about a seizure, sudden change in sensation, behavior, or movement. Seizure is a sign of underlying defect, injury, or disease, and not a disease itself. So most of the seizure calls we get called because somebody's seizing. They're out of the seizure when we get there most of the time. And there's a couple different types of seizures. We have our partial and our generalized seizure. So the partial is only affected by one part or one side of the brain. Patient may or may not lose consciousness. Okay, so somebody might be half seizing or one appendage is kind of seizing, but they're, a lot of times these people are still awake. Okay, and then their generalized seizure affect the entire brain and affects the consciousness of the patient. So these are the people who fall down on the ground, they become unresponsive, and a lot of times they're shaking rapidly. Okay, our tonic-clonic seizures are unconsciousness and major motor activity. So they're unconscious, they're probably laying on the ground, they're flopping around, okay? We have a couple different phases, our tonic phase and our clonic phase, hence the tonic-clonic seizure. Okay, tonic phase, the body gets rigid for up to 30 seconds. In the clonic phase, body jerks violently for 1 to 2 minutes. So what can happen is the body gets real stiff, they'll start flopping around, and they can get stiff again, and that can be pretty serious condition. A lot of times they'll stop breathing during this time. So you look for signs of cyanosis. They may need oxygen when they come out of the seizure. And this may be a test question here. What do we do to affect a seizing what do we do to treat a seizing patient? Move things out of the way in the room. So if they fall down and they're close to a table, where if they start flopping around, they're going to hit their head, move the table. That absolutely will likely be a test question on your state test. So the answer is to move things out of the way. That's the first step, okay? So once they're done with their seizure, they're considered postictal phase, okay? After the convulsions stop, they often slow period of regaining consciousness. So these people, when they're postictal, they're out of it. They're awake, they're looking around the room, they usually look very confused, they can't really answer questions. You say, do you know what happened? A lot of times they're disoriented. That's when they're postictal. Sometimes postictal patients can become pretty combative as well, so just be aware of that. Okay. Some seizures are preceded by an aura. So it's a sensation the patient has just before it's about to happen. Patients sometimes will smell a sound or a general feeling right before the seizure. So they call that an aura. And a lot of seizure patients know when a seizure is about to happen because they'll feel that aura. Okay. Different reasons for seizures. Hypoxia, which is low oxygen, stroke, traumatic brain injuries, Toxins and hypoglycemia can cause seizures. Brain tumors, congenital brain defects, infections, metabolic issues, idiopathic issues. A lot of the seizures we see are people with chronic seizure conditions. Okay. But if it's brought on by, again, hypoglycemia, like we're talking about, or hypoxia, or poisoning of sorts, that can mean that very, very serious. Epilepsy is just a seizure disorder. Measles, mumps, eclampsia, and heat stroke can all cause seizures. So some things we need to ask our patients, or if the patient's able to talk to you or the family member, what was the person doing right before the seizure started? What did they do during the seizure? Because you're trying to figure out, were they having a partial, were they having a tonic-clonic seizure? How long did it last? And what did the person do after a seizure? A seizure is an ALS call because technically the person's unresponsive during the time. And paramedics and I think critical care can give medications that can help bring them out of a seizure, especially in pediatric patients. But we don't give anything for the seizures as basic EMTs. So if you are present when a convulsive seizure occurs, place patient on the floor or ground. They're probably going to fall because that's how we know that it's started. Loosen restrictive clothing if you can. Remove objects that may harm the patient. Try to protect the patient from the injury, but do not try to hold the patient still during convulsions. There was a time where people would say, put a wallet in their mouth. Don't ever put anything in their mouth. No spoons, no wallets, no anything. You don't put anything in their mouth. The only thing we're going to do is move things out of the way and let them come out of their seizure. Loose and restrictive clothing is on this list. If that person's kicking and flailing around, I don't care how restrictive their clothing is. You are not going to get that close to that patient. You don't need to. Hopefully soon enough it'll be over. And once they stop seizing, you can start to worry about those things. The only thing we're going to do, and again, this will be a test question, move things out of the way. That's all we're going to do for the person who's convulsing. Okay, but after we're done with the convulsions, we're going to think about their airway. What position are they sitting in? Did they choke on something while they were seizing? If there's no possibility of spinal injury, position the patient on their side. Okay, put them on their side in the recovery position that we've talked about, right? If there's a possibility of a spinal injury, we don't want to mess with their C-spine at all. We might want to get a collar on that patient. If the patient's cyanotic, ensure the open airway and artificial ventilations with supplemental oxygen. So if the patient is turning blue because they stop breathing, we want to get oxygen. In fact, while they're seizing, we might want to get the oxygen ready because they're likely going to need it. Okay. Patient breathing adequately may be given a non-rebreather or a nasal cannula. Absolutely, we don't need to bag these people if they're breathing adequately. Treat any injuries that may have been sustained during the convulsions. If they hit something, if they broke an arm, if they cut themselves, treat it after they're done convulsing and transport to the hospital. All right, status ellipticus is a term that we use for 2 or more convulsive seizures in a row without gaining full consciousness or a single seizure lasting more than 10 minutes. This is a very, very high priority emergency call. If you get there, because by the time it takes them to call 911, get dispatched, get on scene, some time has passed. So if they're still seizing, there's a good chance this is what's going on here, okay? This is absolutely an ALS call. We need to worry about getting some medications in there, but we need to get that person to the hospital very quickly. Back to the 2 or more convulsive seizures, okay? So you're going from the tonic to the clonic to the tonic to the clonic phase. If they're moving through the phases without regaining consciousness, that could be what's going on here. Okay, not all seizures present as generalized tonic-clonic. Okay, partial seizures like we mentioned here a few minutes ago, uncontrolled muscle spasms or convulsions while the patient is fully alert. So you have one part of your body that's just not acting right. That could be a partial seizure. A complex partial seizure is often preceded by the aura that we spoke about. And then our generalized seizures, we talked a bit about, tonic-clonic seizure, absence, petit mal seizures, brief with no dramatic motor activity, temporary loss of consciousness or awareness, may go unnoticed by everyone except the patient and knowledgeable members of their family. So this is something that can kind of just happen. People will zone out. They'll zone out for a minute. They'll just be sitting there. And this technically an absence petit mal seizure. The patient can come out of it and be like, whoa, what just happened? Okay, that was technically a type of seizure. Okay. All right, we'll talk about strokes a little bit. Strokes is death or injury of brain tissue from oxygen deprivation. So there's two different reasons for a stroke. So a stroke is kind of a general term for blood flow being disrupted to the brain. It can be a clot. So you threw a clot from another part in your body and it gets stuck in your brain and it cuts off blood supply to the other side of that vessel. Or it could be a ruptured blood vessel in the brain where the vessel actually bursts and the blood is now just flowing into the skull cavity, and the brain is not getting the blood where it needs it to. Okay. Signs we're going to see for a stroke would be one-sided weakness. It's very common. Difficulty speaking or completing sentences, or a headache could be caused by the ruptured vessel. It's less common, but it is very important. Other signs and symptoms: confusion, dizziness, numbness, weakness, or paralysis. Usually it's on just one side of the body. Loss of bowel or bladder control, impaired vision, high blood pressure, difficult respirations and snoring, nausea and vomiting, seizures, unequal pupils, headache, loss of vision in one eye. Unconsciousness is uncommon. Let me just back up here for a second. So what we do to test for a stroke is called the Cincinnati Stroke Scale. And what we'll do is we will have them hold their hands out in front of them, close their eyes, and you say to them, you hold them up in their hands and you say, hey, close your eyes for 10 seconds, okay? And you let their hands go, and you want them to hold their hands out. I'm doing this now, even though you can't see me, but you let their hands go, and they should be able to keep them both in the same place. If one drops very quickly, a lot of times that's fake. Some people who are faking it it'll just drop very quickly. I'm not saying that everybody's faking it. I'm not saying that the person who does that is faking it, but I'm saying generally speaking in a true stroke that the person thinks that they're holding both arms out and the one arm will slowly drift down. Okay. The other thing we can look for is a difficulty speaking. So slurred speech, if you can ask them a sentence to tell them to make up a sentence for them to say, like, you can't teach an old dog new tricks is one of the examples that they use, because there's the S's and the K's in that sentence. And if they're slurring the speech, that's an indication. And then what we'll do is we'll have them smile. So I need you to give me a big smile. Let me see your teeth. And you want to see an even smile where both sides of their face are smiling. If only one side is smiling and the other side is drooping, okay, those three things would be an indication of a stroke, in which case we could likely want to let the hospital know right away we're coming in with a potential stroke. And again, as we talked about before with the diabetes and glucometry, we need a blood sugar on these patients to make sure that it's not a hypoglycemia issue, okay? So we talked about that, unconsciousness, communicating with a stroke patient. It's often difficult to communicate with a stroke patient. The damage can affect the brain, okay? So likely whoever called 911, it's usually a family member who says, my mom's not acting right, grandma's not acting right, whatever it is. You probably want to communicate through them mostly. Say, what's happening? When was the last time she was seen normal or he was seen normal? What's their normal? And try to figure out how long this has been going on, okay? TIA, transient ischemic attack. So a TIA is interesting because it's essentially a mini stroke. What can happen is a clot can go to the brain and the person is having all the classic stroke-like symptoms, the slurred speech, the weakness on one side, and then it clears up on its own. The thing is with these TIAs is when they'll call and say something's wrong. You get there and they're starting to get better already. Usually it's pretty quick. So you get there and they're slurring their speech a lot when you get there. You start asking questions, they start being able to answer it. And then all of a sudden it's like, there's nothing wrong. This is because a clot went to the brain and knocked out all those systems. And then the body broke down the clot and then they're back to normal. The thing is with the TIA is a lot of times the person's gonna say, no, I feel fine. I don't want to go to the hospital. We have to instill to these people that a TIA is, in my opinion, God's way of telling you that you have something wrong. And a TIA will 100% lead to a stroke. If you have a TIA, you will have a stroke someday if you don't get this taken a look at. It could be in a day. It could be in a year. We don't know when it's going to happen, but it's an indicator that something's going on. And they need to go to the doctor, even though they feel fine right now. So we really want to try to avoid signing off anybody who is a potential TIA, because you have to explain to them that this is a chance for you to get this taken care of before you have a true stroke. Cincinnati pre-hospital stroke scale, we already talked about how we do that. Okay, there's just a picture of a guy with the drooping on the one side. This is the picture of a lady holding her arms out. Just like I said, you want her to hold her arms out, and then she should be able to hold them up there. If one of them slowly drops down, then that's not good. Okay, can't teach an old dog new tricks. Patient care. For the conscious patients who can maintain an airway, we're going to calm and reassure the patient, which is really a lot of what we do is comforting care. We're going to monitor their airway and consider oxygen administration if we need it. All right. For the unconscious patient who can't maintain an airway, guess what? ABCs is part of our primary assessment. That's a life-threatening condition. We need to manage the airway. Okay. Provide oxygen if necessary and transport. Transport suspected stroke patients to the hospital with capabilities for managing stroke patients. So WCA is a stroke center. So most of us in the county are going to transport to, UPMC Chautauqua. And they're going to decide if the patient needs to go somewhere else from there. Okay. Determine and document the exact time of onset and symptoms. Document contact information if person other than the patient provides time of onset. So if you got the husband whose wife wasn't acting right in this morning when we woke up and you say, oh, holy moly, I think this person's having a stroke, we want to make sure to document the time that she was last seen normal. And a lot of times when this happens in the morning, it's going to be, she was fine when we went to bed last night and we woke up like this. Well, that means the last time they were seen normal was 10 o'clock at night or whatever time they went to bed. You want to get that person, the husband, wife, caretaker, mother, father, son, daughter, whoever's information, because the hospital does want that. So if you can get their name and phone number and document the onset of the symptoms, that would be perfect. The hospital will be very happy with your assessment. Right on to dizziness and syncope. Can indicate serious or life-threatening problems. May be impossible to diagnose the true cause of syncope. Okay, dizziness is a common term used meaning different things to different people. Okay, we could be talking about vertigo, which is a sensation of surrounding spinning. So you get that spinning kind of feeling. All right, lower lightheadedness, sensation you're about to pass out. This is called pre-syncope. Lightheadedness is fine. Dizziness is fine to call it that. And then syncope itself. For those of you who don't know, syncope is a brief loss of consciousness with spontaneous recovery. It's typically very short, a few seconds to a few minutes long. Patients often have a warning sign that they're going to have a syncopal episode, similar to the aura, I suppose. But the syncope is basically a person passes out for we don't know what reason. But a lot of times these things happen with it's more of a postural thing. So some people, if you bend over to tie your shoe or something, and then you stand up really fast and you feel like you're going to pass out. Okay. That's basically what this feels like to the people. And for whatever reason it is, and sometimes it is just them standing up, it changes the blood pressure. So your blood pressure goes from this and you stand up, your blood pressure drops out and your heart rate gets real high, which are signs of shock. It's a mild signs of shock, and the person will just pass out. Okay, that's a syncopal episode. That's a very common call that we get called for. Somebody just passes out for whatever reason. And a lot of times it can be a cardiac related issue, a heart issue. So it is important for these people to go get their heart checked out. Okay. Cardiovascular causes, like I just said, bradycardia, which will be low heart rate, and tachycardia, which is high heart rate, can cause decreased cardiac output and syncope. Vasovagal syncope is thought to be the result of stimulation of the vagus nerve, which signals the heart to slow down. Okay, so one of the treatments that some medics will use if somebody's really, their heart rate is up way too high, they'll tell them to bear down like you're pooping. Just that feeling of kind of pushing, bearing down. And that's a vagal stimulation, and it's supposed to help slow your heart rate down. That's a treatment for tachycardia. It's not uncommon for the paramedics to have people do that if their heart rate's really high. But again, the decreased cardiac output can cause the syncope. Okay, hypovolemic causes. So if you have low fluid or blood volume, person's dizzy when they stand up or sit down. Source of bleeding may not be obvious, so they might have some internal bleeding going on that we don't know what's going on, or GI issue. So it's not in the blood, is not in their bloodstream anymore where it should be, and they'd call this hypovolemic causes for dizziness and syncope. Metabolic and structural causes, alterations in brain chemistry or structure can lead to diminished level of consciousness. Metabolic and structural causes, the inner and middle ear problems also cause dizziness or syncope. So a lot of people with an ear infection, those types of things, burst eardrum can cause balance issues. That's where they come into the dizziness feeling. Environmental toxicology, of course, alcohol and drugs can cause fluctuations in consciousness, and other causes. In half the cases, no cause is ever found, which is kind of strange. I passed out. Why? Don't know. Okay, moving on. It's interesting. Patient assessment. So we'll rapidly identify and treat any life threats. Again, we beat this into you over the class, but the identifying the life threats is every single patient, no matter what condition or why we're there. ABCs. We identify those life-threatening conditions. Gather information that'll be appropriate for overall treatment. Ask them questions. This has ever happened before? Maybe the person says, yeah, I've got a heart condition, and every time I stand up too fast, I pass out. Okay, well, good. Now we know it's a heart condition. You know they passed out because of that. If they say, no, this has never happened before, now we got a new issue that the person has to deal with, okay? What do you mean by dizziness? What does it feel? Does it feel like the room's spinning? Are you just feeling lightheaded? They're kind of different. So try to ask more specific questions. All right, did you have any warning signs? Did you know this was going to happen? When did it start? How long did it last? Of course, the person might not know how long it lasted, but hopefully a bystander can figure that out for you. What position were you in when the episode occurred? Were you sitting? Were you standing? Were you standing up? Were you laying in bed and you just jumped out of bed real quick for whatever reason, then you passed out? That's a big indicator right there because of the blood pressure thing we talked about a few minutes ago. Are you on any medications for this kind of problem? All right, do you have any other signs or symptoms? Any nausea? Did you witness any unpleasant sight or experience or strong emotion? Did you hurt yourself? When you fell down, did you smash your head on the ground? Did you break your neck? I mean, these are very important questions. Did anybody witness involuntary movements or extremities like seizures? So did somebody see the person fall over? Were they shaking? Were they convulsing? That'd be very important. Patient care. We can administer oxygen if they need it. Call for ALS because this is an altered level of consciousness. It'd probably be appropriate to have medic come down. Loosen tight clothing around the neck. Lay the patient flat. Treat associated injuries patient may have occurred during the fall. Okay. All right, there's a TIA video in here. You guys have access to these PowerPoints. This is chapter 19, I believe. So you guys can go back and check out these videos if you'd like. All right, we'll do a quick review. Diabetic emergencies are usually caused by poor management of the patient's diabetes. Pretty much true. Like I said, a lot of people just say, no, not taking my medication, don't want to. Okay, well, this is why we're here. Diabetic emergencies are often brought on by hypoglycemia or low blood sugar. Chief sign of hypoglycemia is that altered mental status. Whenever a patient has altered mental status, the history of diabetes, and can swallow, we can administer the oral glucose. If they can't swallow, we administer nothing by mouth, okay? Seizures may have a number of causes. Assess and treat for possible spinal injuries. Protect the patient's airway and provide oxygen. You should gather information about the seizure and give it to the hospital. A stroke is caused when an artery in the brain is blocked or ruptures. So again, a stroke is either a clot that's thrown into the brain or a blood vessel ruptures. Signs and symptoms of a stroke commonly include altered mental status, numbness or paralysis on one side, difficulty with speech. We got to do that Cincinnati stroke scale for these people. For stroke patients, ensure an open airway and provide supplemental oxygen. Determine the exact time of onset and symptoms and transport promptly. Dizziness and syncope may have a variety of causes or an unknown cause. In the case of a syncope, administer oxygen, loosen clothing around your neck, and place the patient in a flat with raised legs if there's no reason not to. Treat any injuries and transport. Remember to determine if the patient's altered mental status is being caused by hypoxia. That's the most common cause of altered mental status. In a patient with hypoglycemic emergency, determine whether the mental status will allow for the administration of oral glucose. So again, make sure that they can swallow. Assess the seizure patient to determine the need for artificial ventilation, if we need it. If the person's breathing adequately coming out, you might not have to ventilate them. You might have to just put it on a breather or a nasal cannula on them. And determine when the symptoms of the stroke began. Very important. When were they last seen normal? What is the family member's name and phone number? Hospital needs that stuff. Questions to consider. List the chief signs and symptoms of a diabetic emergency. These are some questions for you guys to figure out on your own, okay? List some chief signs and symptoms of a diabetic emergency. Explain how you can determine a medical history of diabetes. Explain what treatment may be given by an EMT for a diabetic emergency and the criteria for giving it. Explain the care that should be given to a conscious and to an unconscious patient with a suspected stroke. So what's the difference between a conscious and unconscious patient as far as managing their stroke? Explain the care that should be given to a patient who has experienced dizziness or syncope. All right. Thanks, guys, and we'll continue these lessons along in another video. I apologize for the noise and the skips here and there. I am doing this at work, so there's dispatches and people, and I had to pause the video once. So I apologize for the poor quality of the lesson, but all the information is there, and I will talk to you soon.